Hello, everybody, and welcome. It is THCB Gang back after a hiatus of a week. It is episode 21, happening on August the 13th, 2020. I have a fun, little smaller lineup today, so we should have a bit more conversation. We had some chaos in recent weeks. We're going to have a bit more fun with some regulars, but some folks who haven't been on for a while in the regular group. So, who do we have today? Great friends, great colleagues. Grace Cordovano, our board certified patient advocate, all the way from the crisis of the tri-state area in New Jersey, which I just hear is ticking up again in the world of COVID. Maggi Cary from Washington, D.C., Dr. Margaret Cary, and Margaret Cary, MD. These days, more of a doctor coach than a practicing doctor, but has a lot of experience in all that world. Vince Kuraitis, old lag and buddy of mine from Better Health Technologies in the wilds of rural Idaho, and Ricciardi, former head honcho consumer at ONC, but these days the CTO, which is the Chief Transformation Officer rather than Chief Technical Officer of startup Carium Health, which is based in California, but she's hanging out also in Washington, D.C. All right, let's go live and have everyone on. It has been quite a week for me. I don't know about what you lot have been doing. We were off last week. In the world of digital health, we had the biggest merger ever, which was the Livongo and Telehealth one. And actually, quick promo, Jess the Master and me have done a long and complex program about that, which is going to be released hopefully tomorrow. And then a bunch of other stuff happened, including some local politician from the Bay Area got named vice president candidate. So it's all going to be fun. All right, so that's some of the stuff I remember for this week. But let's start. Vince, as you're outmanned or outwomaned, which is kind of appropriate given what we just saw from Joe Biden. Tell me what you've seen for this last week.
Well, I'll pick up where you started. I'll make a couple of comments on the telehealth market. I think investors got this thing wrong when they saw this merger, and the question I'll pose is, where is the long-term value in telehealth? And to answer my own question, I think it's really around where value for patients and value for investors is really around integration and creating platforms and networking a fragmented healthcare system. So the initial dive of the stock prices was really missing the boat. The other comment I'd like to make is around beginning to see pushback around the growth of telehealth, where the dinosaurs at our favorite medical association, the American Medical Association, are making noises about wanting to go back to the old ways. For example, the separate licensure on the state level, really a Neanderthal way of looking at the world, in my opinion, but totally to be expected when from the last 30, 40 years, I would say the health system has been built around the needs of clinicians much more than around patients. A couple of opening comments, and thanks for the chance to be with you today, Matthew.
Fun to have you on, Vince, and I like it. And you're giving just 30 or 40 years of that being the health system, probably more like,
longer.
10,000 years. Grace, from the point of view of patients, what have you been noticing?
So yeah, in the same way that you were excited and probably had a lot of buzz about Teladoc, Livongo, and all these big announcements, patients are left sort of frustrated because we seem to have skipped a step. And to Vince's point about value, where's the policy making about prescribing Wi-Fi and smart devices to level the playing field? There clearly is a lot of money involved here, but are we really putting patients and their loved ones first in managing chronic illness and all these comorbidities? And the other announcement that left me sort of very frustrated as a step backwards is the announcement about Cerner and Zelf. So I was so disappointed to hear that the library is all of digital care tools is only available to doctors to look at. So if we're really going to transform, the people who really do a fantastic job of managing chronic illness are the patients' families and care partners. Wouldn't it be wonderful if we could just blow the doors off the library and give people who are so desperate to bring the best care to their families so that they can research what works for them to meet their goals and bring it to the doctors? So I feel like this was such a paternalistic approach, and we do everything multi-channel, step, and here we're just going right to the doctor. So who are we really bringing value to?
Well, excuse my friends itself about that. Lygeia, you're in you work for a company these days which is to help consumers communicate better with doctors and many others.
Right.
What have you been seeing this week?
So I can't not comment on the Teladoc Livongo thing as well, just because it's so massive in our industry. And I generally think it's a positive sign forward. I mean, notwithstanding Grace's point about access to data, I think that part of the value creation is in prevention and in ongoing management of conditions, and enabling that kind of service to happen in addition to just acute treatment is going to be really important. And I do think that we'll need more policies, for example, from the FCC to further extend access to broadband and that kind of thing. But it's also hard to sort of bake all these things in at once. So you sort of like push from one area, then push from another, then another. So I saw it as a general positive push in the right direction for consumers and the field.
Maggie.
So 3 things. Number one, I was sort of concerned with the idea that Medicare and Social Security might go away, because that's going to affect a lot of poor and old people. The second thing is that—
Hang on, slow down. I missed that. Medicare and Social Security going away.
the man we love to hate has proposed that payroll taxes be decreased, which means the money doesn't go into Social Security and Medicare.
He didn't actually say he wanted to abolish Medicare and Social Security. He's not quite that crazy. We'll see. So your second and third point.
If you follow it through, right? Second thing is always follow the money. I mean, I've coached docs in very senior roles, and it's all about the money, and has been for a long, long time. The third thing is that patients can easily get to Medline and Grateful Med, and that goes into another point I'm going to bring up, and you guys are all going to shoot me. But my agent, literary agent, wanted me to write a book on how to find a good doctor. Spent a lot of time on a proposal, put it together, and all the major publishing houses, the big names, said, we don't want it because nobody's going to buy it. They don't look for a doctor, and they don't look for healthcare until it's too late. And there was one textbook company that wants it, but I've already written a textbook. I'm not interested in that. And so I wrote an article called Doing Due Diligence on Your Doctor. I sat on the state medical board in Colorado for 8 years. I got a chance to see, how you really investigate your doc. And truthfully, people just aren't interested in that. So I know that those of you who are advocates for patient care, I mean, part of it is the patient's responsibility. And what I'm hearing from people who sell stuff around that is they just don't care until it's very late.
Not true.
I don't disagree with a word you said.
All right. So let's hold on, because Maggie hasn't got to a third point yet.
I think those are all mushed. They're all
mushed together. All right. Well, I'll let Grace, and then I'll let open season on people beating you up. But but after I say a couple of quick things about what I've seen this week, 3 real quick points. One is the numbers coming out notice that hospitals and health plans have had very profitable second quarters, despite the fact of all the doom and gloom we heard about COVID. We expected that for health plans, not so much for hospitals. Second point, not the Livongo Teladoc story, but instead Oak Street Health, which is a new startup clinic, came out the gate for its IPO, incredibly highly valued as well, valued at something in the order of 20 times revenues, backed by Humana and some other big players. But an interesting company, but again, stock market craziness. And the third point we want to mention, finally, on the ticket, we have a female minority African-American plus Indian immigrant candidate. I'm not sure it's going to make a big difference to healthcare. She was, though, a little more single payer at the start. Kamala Harris was a little bit more single payer at the start of the campaign. She's going to walk that back. She didn't stay with Bernie and Elizabeth Warren in that camp, but worth mentioning for that. And then my final point, there's a lot to spiel this first part, is that Bob Wachter has been talking on Twitter about what's been going on at UCSF and in San Francisco, in California, and UCSF is now back to the level of elective surgeries it was before COVID started. In other words, if we were dealing with, if that's reflective of the nation, and we're dealing with a whole bunch of unnecessary surgeries and procedures, as Brian Clapper and Shannon Brownlee and others who've been on the show tell us, we're back to where we were. All right, Grace, open season on Maggie.
You know, I'll give you an example. I had a parent that reached out to me. We've been working together for a few months, very casually, about trying to figure out due diligence on the best surgeon, neurosurgeon, to do a very intricate procedure on her daughter that is disabled. And she had this question, well, how do I find out about the performance and the outcomes? And I can read their bio and I can see all the academic memberships and all of their publications, but how do I trust my child's life and the outcomes and what's going to happen, as well as the investment and out-of-pocket expenses? Who do I go with? And I see this all the time. Once you hit a life-altering, life-limiting diagnosis, patients are really blindly going in there, because for any cancer treatment, for any rare disease, disability, any kind of multiple chronic illnesses, when you have multiple moving pieces involved, you have no idea, because nobody reports back what the outcomes are, what the medical errors are, what the failure rate, what the hospitalizations, what the hospital acquired infections, deaths, and all the other issues that can happen. So it's a great point. And I would love to talk to the people who told you nobody cares, because that's a lie. It's a flat out lie, and it's a big concern. And it's a big concern for the families also, because a lot of these situations, when you need to do due diligence, it's a whole family involved, and people have so many questions that if they had a resource, the reality is that we can't do due diligence because we don't have all the information available in the public domain. And that's a huge, huge problem.
I don't disagree with you. I think we see the world in a slightly different way. And there is information available. It's just piecemeal. For instance, New York publishes cardiac results, and it's interesting that when Bill Clinton had his bypass surgery, he chose the hospital with the highest rate of complications, and he had a complication. That was on, I think, the front page of the New York Times below the fold years ago. Doing due diligence, I mean, it is work. And so I just send my article to you if you want that. I just sent it out to a group, and they said, oh, you should publish this. Well, I just send it out to people who are interested. And I think what if you look at Judith Hibbard's work out of Oregon, and if she in fact is still researching, what she found is that patients say they choose their doctors from quality, low error rates, and they really choose them on if their friends said they liked them. Yep. And I was on the state medical board in Colorado for 8 years. The governor appointed me, and I'll just tell you a little story. I think I may have said this. 2 of the docs there did plastic surgery, and they were very bad. But we were not. Their patients love them. And our job on the medical board's job is not to go out and be policemen and find things. It's to investigate things that come in. I was chair for a while, and there was nothing we could do because patients loved them. So I just it's a little more complicated. I think I just see it in a little bit different way from you. I think.
It's
I'd like to share a few perspectives, if I may.
Go on, Vince.
Well, so I spent 10 years working in an integrated delivery system. And in terms of learning about the local medical community, I would describe that as what I heard anecdotally was sort of the rotten tomatoes of good bad doctors or good bad movies. And if I had to ask one person in the local community about choosing a doctor, it would be the quality control director at my local hospital, who picks up, at least you can eliminate the bad movies through Rotten Tomatoes, or you can eliminate the bad doctors. And there were lots of doctors that I know people wouldn't send their dogs to in the local community. But how do you get that kind of information out into the world? And I'm curious, Maggie, what you wrote about in your article. What kind of information is really valid information to be able to pick a doctor? It's not intuitively that obvious.
So it's interesting. What I suggested, there's a few things I suggest, and one is that you go to the state to see who's been sued. Now, Colorado, for instance, and any doc that's been sued even for 1 penny is listed, or at least they were when I was on the board. California had at the time a $30,000 price difference. I mean, it had to be at least 30,000 or they didn't report. And I think now every doctor these days is going to have a malpractice case, especially
Yeah, they
neuroscience.
all do. And
Or-
and getting sued means you've taken on hard cases. And do
Well-
you want doctors who haven't taken on hard cases?
So I'm going to push back on you a little bit. So hear me out.
Please do.
Hear me out. It may or may not. It depends on the intensity of care and and what you had to do. So that doctors in the high risk categories have all been sued, and things like family medicine, dermatology, not so much. And I think what you're looking for with anything, it's with trends. It's not to say, hi, they've been sued three, but it's to look at trends and see what they've sued for. Again, when I was on the medical board, doctors that were horrible, and I had a chance to actually have to talk to them when I became part of CMS in the Clinton administration, because I had to say, you know, this kind of looks like fraud. I know you didn't mean it, but it looks like. And so I think it's really about looking to see how many suits and where. I wish patients could have the National Practitioner Database info, but they're not going to get that. It just isn't going to happen. And the other thing to look at, I always say, go on to Medline, go on to Grateful Med or whatever, find a search term. Now, if you do hypertension, you're going to get a room full of papers. But if you can narrow it down, see who's doing the research, see who's doing the research and what you're looking for, and the rare disease. The other thing is go to rarediseases.org, which it's run by an MD PhD I used to coach. He was a guy named Jimmy Lin, who's really good. And he has a whole database for the genetic differences he did this not for profit. He doesn't make any money from it when last I heard, but he has all the genetic sequences for the rare diseases. If you're looking for things, it's going to take a long time. And that's why I think, these are Random House, the big publishers said, nobody's going to buy the book, because by the time they really need a doctor, it's kind of too late. They're more focused on, so if you come into the emergency room and you're about ready to bleed out, you really want somebody to just take care of you and get it done. It's much different from a leadership style when you're going in to see a doctor in the clinic. And just like with patients, by the time they usually get around to it. And the other thing I have to tell you is that many, and you're going to shoot me for this one too, is many patients expect the doctor to do the work for them. And they don't realize that I can't lose the weight for them, or I can't take away the risk factors, right? And that's where other people, other professions come in much more better, health consultants, health coaches, things like that. So I think it's a complicated problem. It's just, I've sort of seen it from every angle. And I have to say, the healthcare system in this country is irretrievably effed up. And I don't even, can't say that word, which if you knew me, you know that I do use that word once in a while. So,
let me put a couple of things in context about the effed upness here, right? So all the way back, I gave a talk at Health 2.0 with Michael Millinson, 2016, 2015, and we were discussing the 100-year-old app, which was Ernest Amory Codman's scorecard that he created for surgeons in Boston in the 1910s. The 1910s, but 1915, 17, right? And talk about the AMA, Vince, he got kicked out of the local Massachusetts Medical Society for calling them, a bunch of ostriches with their head in the ground. Nobody else in the surgery group back then, and for about another 100 years, really wanted to keep score because, you don't want to admit that mistake. You don't want to give the lawyers the chance. So there's that issue. There have been attempts to build online versions of your book, Maggie. Vitals and some others sort of built this around rating doctors, the sort of Yelp for doctors. It's really hard to do because all the measurements about what matters, as Grace said, she brought in a lot of issues at the start, which weren't necessarily the doctor's issue, it was at the hospital. You're not buying a branded one thing in healthcare. Right. You're buying, this for this. That's why they have this issue around, surprise billing. There was an assistant surgeon in the room who I never knew and sent me a bill for $20,000, right? You get all these things which are, who's really influencing that care and that decision on the team? And then how much of it's been done, is issue with the patient. I have had a look at some of these, some data suggesting that the psychological state well-being of patients when they go into surgery for things like hernias, how they're feeling and where they are on depression scale has a big impact on their outcomes. So there's a whole bunch of stuff going in here. And to try to loop this all back to the thing where we started with the Teladoc Livongo, for that matter, Oak Street Hellfire, all the rest of the people who are trying to build more of a platform, is do you have to bring all these pieces together to service a patient? I mean, before you can talk about it's not a doctor we're finding, it's do we need to be building a more comprehensive service platform, which includes doctors and a bunch of other people, and that do we have to choose between those? I mean, maybe that's where we're heading. We're obviously not there yet. I'll shut up, Lygeia. You haven't said nothing for a while.
The problem can get huge and overwhelming really quickly. And I agree with you, maybe all, that the system is kind of effed up. But I think that there is certainly a case for educating people, patients, families, the public, that it is important to find a primary care provider or some way to get your care when you are not in a desperate situation, because you need to have that person as kind of a contact, a coach, an advocate for you already on deck when you get COVID or get diagnosed with a chronic condition, or they're going to be looped in if there's an emergency. So that's one place to start. I do think that patients, many do care, I'd agree with Grace, about the quality. Like, of course, who wouldn't choose a surgeon who has a better record than a surgeon who doesn't? The problem is that we don't often have the opportunity to make that choice. That information isn't out there. And I would even say that consumers don't fundamentally understand, many, the variety in levels of care that they can get from providers. There's this myth that like doctors know what's going on. And many people don't know that there are some who might be extremely competent and others who aren't. So that's another issue. But one more thing I wanted to bring in that makes this also a little bit more complicated, particularly in primary care. I would argue that to a point, in terms of the quality, there are some providers who are better than others, although that's hard to measure. But there's no universal scale for like an awesome doctor or a bad doctor when it comes to who's a good fit for you. So for example, particularly with primary care, I want a provider to work with me, somebody who's really collaborative. I'm going to go and read about whatever it is and have an opinion and have a back and forth. I understand not every patient takes that approach. Some patients really do want you've boiled it down, you've told me to take 3 of these and call you in the morning kind of thing. So it's a personality, it's a trust thing. That's another dimension of these things that matters. But I think in general, this idea of you underscoring the importance of taking a role as a patient in thinking about who's going to be there for you, particularly in a non-acute situation. That would be like a really smart thing for all of us to do, particularly in the middle of a global pandemic where lots of issues are coming up and they tend to be complicated.
So I once read an article and I said that for my family doctor, I wanted mom, but for my surgeon, I didn't care about bedside manner, but that was gravy. And then I read an article and actually wrote one on the Doctor Weighs In, that surgeons that work in a system where they're nice to their patients and the staff, whether they're nurse, things say like, how are you doing? Actually have better outcomes. And I just finished reading Bill Bryson's book called The Body. Boy, I have to tell you, it was much better to explain the human body than medical school was. I finally got all those immunized cells, what they did, the T cells and the B cells. And I mean, it was like I finally understood it. And
you can go back into practice now, Maggie.
I'd like to offer an optimistic, longer-term view. I've been rereading a book called The Square and the Tower by British historian Niall Ferguson. And he makes a point that there's been 2 times in the history of man where information has been dramatically increased and available. One was in the invention of the printing press in Gutenberg a number of hundreds of years ago. And the second one is the one where we're living in right now around the internet. He traces it back to about the 1970s. So, you take the 50-year or the 500-year view, we're not there yet in terms of the value of or the accessibility of information for patients, but it's sure gotten a lot better in the last 30 years. And I think it's going to continue to get a lot better. So, take the longer view here. I think we're definitely in the right track, and it will continue.
I'll quote a British economist to you there, Vince, a guy called John Maynard Keynes, who said, "In the long run, we're all dead." But I mean, you're right.
I got to go in that case.
No, look, we clearly know a lot more than we did, and some of what we're finding out is not fun. And it all reminds me of kind of like the issues about the sort of the MAG idea of getting everything great again and going back to the 50s or whatever. If you actually knew what was going on back then, the sort of Mad Men era. I mean, just take something like Me Too versus the Mad Men era. What about how things really were back then? Everyone thinks things can be rosy, but in fact, while we had the family doctor relationship and the halcyon days of American medicine in the 50s and the 60s and the 70s, I'm sure there's a ton of bad stuff going on. One slight worry I have about Maggie's idea about going to the medical board is that the studies I saw when I was doing health services research, and admittedly I was in the academy back in 1989 to 93, so not exactly current with all the latest literature, but the studies were showing that there was a lot of malpractice going on, but that about half the malpractice that was going on did not result in a lawsuit, and about half the lawsuits were for things that weren't malpractice. So like the Venn diagram between which was malpractice and which wasn't, didn't cross over that well. So I'm not sure that, there are bound to be people who show up in the medical board a lot who really are bad actors. And yes, those bad actors have often been kind of hidden and moved around with the medical community, a bit like the way the Catholics did it with the priests. But, I think this stuff is all getting better. But we don't really have a good way of getting at, Grace's problem, especially when you get into the rare diseases and the intricate stuff. So I think this is a problem. And even if we build these platforms for whether it's, Optum and United or, the big local systems or Telehealth, Livongo, whoever it is building a platform that is promising to take care end to end of everything that happens to be with kidney disease or diabetes or asthma or whatever it happens to be, there are still going to be enough people with rare, undiagnosed or misdiagnosed conditions, who aren't going to fit into something that can, quote unquote, scale in the Silicon Valley terms. And I don't know if there's a good way of figuring that out.
I have an idea. So going back to one of your points, Matthew, about whether these new platforms need to be so comprehensive on all the data and offerings and tools and remote patient monitoring and data access points. No, I don't think so, but they do need to be comprehensive in their strategic leadership and including the continuum of patients and voices to make sure that it's equitable, diverse, and actually tackling real world things. Because if you pulled in patients, and not like your token patient, but look at the leadership boards of any of these huge names, I don't see any patients on there. So it's the same thing. We're trying to push from the bottom up. And I don't feel that there's enough prioritization. And every single mission statement says, we're going to transform care. We're going to transform and make it patients first and put care back into the lives of patients. But we're missing the very component that needs to really drive this. And that's having the patient and the care partner voice. As medicine has become more and more specialized and sophisticated, a patient alone can't do a lot of this work, which is why care partners are now so much more involved. Family, friends, spouses, children, the sandwich generation. I mean, there's children navigating healthcare because there's language barriers and limited English proficiency. Kids, okay? I did it as a teenager, as a 12-year-old for my family because I didn't speak English when I started school. My family's from Poland. Even though I was born here, everything was Polish at home. Once I got the hang of it, I became the go-to English-speaking person to translate for my family, friends, and local communities. And there's plenty of this happening everywhere. We're not supporting those people. So I have my doubts. Lygeia, I know you brought it up that it's wonderful, and there's a lot of wonderful things happening, but we're not going to change unless we recognize what the real world needs are.
I'm just shocked because Lygeia had 2 years at ONC to fix this, and can't believe you didn't do it, Lygeia.
I also spent some time at the FCC, by the way, trying to help get access to rural areas, and that's not entirely fixed yet either, but we did make some progress.
I don't know what you guys are doing in DC, my word.
So Lygeia, why are we know about this? We've been talking about it. You've lived it. What needs to be done?
I mean, honestly, I think at the end of the day, it goes back to the issue of money and how and where it flows. And if consumers had more direct buying power, they're not the customer. That's the problem, really.
Right.
But I'd argue there's an interesting thing going on in the healthcare system at the moment, right? So we tend to think, and we all go on about primary care. And I think if you look at the new primary care clinics that we all look at, forget the stock market part for the moment, because that's its own set of craziness. But if you look at Oak Street or Iora Health or one of those companies which is doing, or even Healthcare Partners or CareMore, or one of these big medical groups that's looking at specialized primary care in general for a disadvantaged senior Medicare Advantage, dual eligible Medicare, Medicaid population, they're all doing this great work. They're all doing innovative stuff. They're all having coaches talk to people on the phone. I'm blank his name. Rashida Fanopoulos. I don't mean Rashida, do I? I do mean, yes, I do mean Rashida Fanopoulos. Iora tells a story about how he sends people on the bus to go to the house of the elderly people with diabetes, and how he how those coaches help them get on the bus and go to the gym. And I guess they don't go there at the moment, but you get the point, right? So there's all these new wonderful things going on. And by the way, it's not that new. I remember meeting Gloria Meyer and her colleagues at Friendly Hills, which is one of the first Southern California medical groups to do this back in the early 90s, late 80s. And they were, sending people out to the houses and helping out, with bathroom rails when they lower in the bathroom, what have you. And the CEO of Oak Street Health, an interview with him last week, saying he was on a home visit, and what were they doing? They found that the patient was lowering herself in the bath on the sink, and the sink was going to break, so they sent a plumber around to fix the sink. I mean, you got all this kind of innovations of changing the life and helping them all. But having said all that, there's this great, wonderful new ways of doing things going on. In the end, we live in a society in which all of us, certainly me included, are sitting there with the ability to get instant gratification on demand for entertainment, food, God knows what else. We know that all of those pressures take us away from leading the good, healthy lifestyle we like. Plus, we happen to have the pandemic, the pressures of living in, modern, diversified social media America, all these other forces which are kind of driving us the wrong way, perhaps sort of mental health, social health. It's not surprising that it's hard to get people to quote unquote change, even though you've got now all this money and all this attempt by these new platforms to sort of bring behavioral changes and nudges and all this great stuff towards us. So I'm not, that surprised that, you brought up Maggie. Well, it's all very well how great the doctor can do, but what about the person, trying to lose the weight or trying to manage their conditions? It's really hard, and human beings are fundamentally lazy, and we don't want to put in the work. So I'm not sure this problem gets solved, because if you have to get to outcomes, you have to change the whole of society. We're not very good at doing that.
Well, and then we could get the food industry, and that article in the New York Times Magazine about how the food industry manipulates food to make it so we want more, with more sugar, fat, and all this stuff. So, I mean, they're kind of working together.
Yes, I agree with you on that. I think the food thing, and particularly sort of subsidization of corn and sugar products and all the rest of it, huge. I agree with you. And that is not often enough linked to this as a policy issue that should be called out.
Well, Matthew,
worth noting that sorry, let's go on.
I'm going to be optimistic again and push back on you. I'll pose a question to the boom in telehealth. Are we about on the cusp of making telehealth or virtual care the default? The behavioral economic nudge.
Depends on if they can work out where the money's coming from.
Yeah, I agree with you. The money is going to be the bottom line here.
But there are two parts of the money, right? One is Medicare is now paying, equal parity. Now there's more stuff you can do if I get you into a clinic. I can poke and prod and do stuff which I can't do in telehealth. But just for the basic visit, it's parity, and you can start to see people making money. As I was mentioning, we're building all these primary care clinics, and if you look at them and look actually what Bob Wachter has been saying the last few days about where UCSF is, they're probably about, they went to like 80% telehealth, and they're probably back down to 30% or,
Right.
But there's a decent amount there, much more than there was, right? And by the way, this doesn't take in the other thing we haven't mentioned, which is for healthy people who want, a pill to support a certain part of their anatomy, I'll point to the top of my head for one example. There's a whole bunch of venture funded companies like, Hims and Roman and Lemonade, who you can basically do an online questionnaire visit for a very small amount of money and get and receive pills. But also, they're drifting the diabetes care, and they're drifting the mental health care, and they're doing other stuff as well at a much lower price. So I think that we're breaking up primary care to a certain extent. But if we come back to the food issue, what does telehealth got to do? So if you think about the broadest context of telehealth, which includes remote patient monitoring, coaching, all the great stuff, and just go back to what the folks at Livongo are trying to do. They have people with diabetes. Of course, food is a huge issue with diabetes, as well as exercise and medication, etc. And a lot of what they're doing is tracking in virtual real time how people are doing with their blood sugar, which means, you had too many beers, you had a big piece of cake, whatever, get you on the phone. Can we nudge you away from that? So it's there. But as Maggie says, and as Lygeia said, on the other side of this, you've had the food industry pushing completely the other way. It's subsidized the wrong way. It makes more money by making these processed foods. And by the way, they're nicer to eat.
Yeah, I think the one way in which telehealth can combat that is if you have a connection, not just to data that lets you know, hey, you ate cake and there was an issue with your blood sugar, but if you actually have a human who can connect you and be like, Matthew, nice job. I noticed today you only had 2 beers rather than 5. Keep it up. Like that gives you your own, joy and positive reinforcement. So there's that's part of how we can counteract in some way the positive reinforcement that you get out of a beer or a bag of chips.
There's definitely, and I haven't managed to drag her on the show yet, but Susanna Fox, who's a good friend of many of us, has talked a lot about peer support. And it's clear that in a lot of these areas, not just in food addiction, but in quote unquote more serious addictions like opiates and cigarettes and alcohol and gambling, God knows what else, peer support is a huge part of that. In fact, there's a brand new, talk about food issues, there's a brand new startup which I've been in connection with, not advised to do, but a good friend of the CEO called Christina Saffron, that's called Keep Behavioral Health, which is basically for eating disorders. It's the reverse of eating too much is eating too little, which is actually a big problem for many people. And what they're doing is basically doing a bunch of support, but it's mostly getting peer support out to a number of different for a number of different areas from people who've been there before. So I agree that works, but I don't think it works for everybody. And I put myself as case number one. I've been in one of these programs that it wasn't Armada, but it was another one. I forget which one it was, the Blue Shield trying to get me into. And they wanted to get me into their first program, which is to write some affirmations about how I was going to become thinner and happier and better. And I just couldn't get my head around doing it, and I didn't do it, and they kind of stopped. So, it's got to be the right approach for people. And there's probably, a group in the middle, people who were going to do it anyway. There's a group in the middle who you could probably push one way or the other. And there's probably a group on the end who are very hard to motivate. And that probably goes for most disease cases, I would guess. I don't know.
Well, you're right. And I just have to jump in, though, and say a piece of this is the environment, both the social environment, but also the physical environment. If because of Corona, you are stuck inside and you've got your TV and whatever, and maybe your neighborhood isn't safe, et cetera, that's a different situation than if you have to or get up and walk to work every day or whatever. So environment matters a great deal. And that goes back in part to the policy thing. It's something that we can influence somewhat as individuals to the extent that we have choices, but it also has to do with things like being in public parks and that kind of thing into neighborhoods and making sure that different kinds of activities are accessible within all kinds of zip codes.
Yeah, I'd also add some. I'll come back to you in a second, Maggie. I just add one thing, talk about politics and Kamala Harris, right? What we heard out of the Obama White House, particularly not from him, but from her, from Michelle, right, was a lot about let's move, get active, healthy eating. That message was getting out. It's not really, I would say, it's a minority message, let's face it, in all the volume of messages we get about food and behavior, but at least it was coming. And, what are we hearing out of the current White House? This stuff's all crap that, dude. I don't know what we're hearing out of them, but we're certainly not hearing a coherent message about how you should look after yourself, which is not the case by in other countries. You look in Europe and Japan and it sounds to me in South Korea, you get a lot of messages. In Japan, I know they do it like we wouldn't put up with this here perhaps, but at work they do a weigh-in every year and they sort of manage, and you get sort of push towards that.
Mm-hmm. So I want to just point out that a lot of the things that we're talking about, no one has taught people how to actually correlate their food directly with blood pressure or sugar or all these different things. That's a life skill that we in the United States don't teach. I have a few patients and families that I've been working with because of COVID in New Jersey when we were first hit. They were so petrified of going to the emergency room. My mom is one of these people who for years has always struggled with blood pressure issues. That fear alone, she uses her virtual visits. She monitors her blood pressure. She monitors her diet. She now writes down what she eats. She can see if she's had Chinese food, even if it's like on the healthy menu, that increase from her diet. Her doctors have been telling her, this is from your diet. Now she sees it on paper and she says, wow, my blood pressure was very high yesterday. I really can't eat these things. So it works. And something so simple that we haven't taught people is, well, you know what? Correlate it. And how do you have to do this to manage it? Because then a light does go off. I'm not saying it's for everyone, but if the patient doesn't do it, maybe there's a care partner or family member who really could be that internal coach. I think we need to push to try to build that support and that warmth around the patient as much as possible, which I don't think we've been doing a great job of.
So I'm going to suggest that each of you try Free Libre. It's a thing you put in your arm and it measures your blood glucose. Now it's interstitial. Now, so I tried it. I did it for 2 14-day sessions. I'm not diabetic. My blood sugar hangs out right about 100, just below, pretty much all the time. So my friend who's the endocrinologist who gave it to me said, try eating something you don't normally eat. And my friend made homemade chocolates. I brought them to my house and I ate 5 of them. Now they were small, but I ate 5 and my blood sugar jumped up to 150 something. And so I had right in front of me proof about what it does. And if you and it's a little sensor that goes into your interstitial fluid on your arm, the back of your upper arm. Doesn't hurt at all. You just put it in. But it's very interesting. I think everybody should try it and just see how you react.
Where do I get one?
I think you have to get a doctor, Maggie, to prescribe one, because I've actually looked into this too. And I would love to. I mean, I think it would be great. And I feel like it would be a really important public health tool, potentially. So
what if you could teach people in an office visit? What if that became, you know what, today we're going to do you do food challenges when you're at the allergist. What about just basic salts, right? Show what happens. What happens when you don't drink water all day? Because how many patients dehydrate based on their medications and go to the ER because they've passed out? They are dizzy, they have, then they go into a panic attack because they think they're having a stroke. These basic things, primary care, we're not doing it. I love this idea. And here's a way to talk about digital health and self-monitoring and all the things that we don't have from a health literacy standpoint.
So while you're all talking about that, I've just taken my own blood pressure on the desk and I'm pretty up because this is exciting. I had a stressful day and I'm up, 8 points on the diet, probably 6 points from where I usually on the diastolic, and my systolic goes all over the place. I once had it measured on stage at Health 2.0 while I was having a really, really tricky time, and your diastolic stays around, but your systolic goes all over the place, and you have to balance it out. But it's clear that if I go for a run and come back and sit down and relax for a bit, I go back to below normal, but I tend to spike up. But these things go in waves, and I think the same thing is true with the CGM, continuous glucose monitor, like the Freestyle Libre or the Dexcom that you mentioned, Maggie. I did have one. I was given one at the party by the folks at Livongo because they were trying to push them. I went out that night. They were going to measure me the next day at their conference. I went out that night and I drank as much sugary alcohol as I thought I could possibly do. And I couldn't get myself into the range of, where a diabetic would be in trouble. So my blood glucose seems to be under better control. But
try harder, Matthew. Try harder.
I should have tried.
Hey,
I wasn't
Matthew.
comatose in the gutter. By the way, Jess Damasio, who was on, you said it wasn't painful, Maggie. Jess Damasio, we have on here a lot. I work with a lot. She had it put in. She's very, very skinny, and she had it put in by the chief medical officer of Livongo, by the way. And I said, I think you better have malpractice insurance, especially for this, because she went in about 3 times, it wouldn't stick, and she had a big bruise on her arm. Oh. But in general, they, I think where you're going with this, or where we could go with this, is that if you go back to the telehealth platform, remote patient monitoring, we are now on the cusp of a lot of this monitoring devices, a lot of this tracking, and maybe Lygeia, you could talk a bit about how you're doing this at Carium, becoming so cheap, essentially free or very easy to do, that, yeah, maybe you have to get it from a doctor, maybe you don't, but it's coming to the Apple Watch, which is now doing EKGs. Samsung Watch can do an EKG. I don't think it's do blood pressure accurately. There's a bunch of people building tattoos. This stuff, 10 years down the road, is going to be cheap and easy to measure, to track all over time. And we're really going to find out what variation is, what's normal, and more importantly, does it matter for interventional health? And then what can we do about it? I don't know. Well, Joe, I'd love to hear a bit about where you guys, carry it.
Yeah. So we have a particular emphasis on RPM right now, in part because a lot of healthcare providers, maybe not the hospitals you mentioned, but some of the smaller ones really need to bring in revenue right now. So RPM is basically, it's the CMS program that gives money for remote patient care, and it's really focused on chronic disease. But we do have some customers who started off just working with patients who were, for example, diabetics, and have expanded use of devices and our platform to all of their patients, partly because of the context of COVID and people being afraid, like what Grace is talking about, to go into the into the healthcare system, it quite appropriately so in many cases. But yeah, I mean, it can be very economical and can really help people understand the impact of their, of their actions on a minute-to-minute basis. I think a critical thing that we've seen, though, is the importance of that, like understanding the data in real time and having a coach intervene. So most people, there are some people who can like track and follow their own data, but what you want and what we provide is like basic parameters, like this is an okay level for your blood sugar. If you're outside of that, it triggers something, so that the patient themselves and a coach or other professional on the other side can reach out to them and say, what's going on? Do we have to take this further, by changing your behavior or even having you come in for something? But yes, I think that's part of what's super exciting about telehealth in the big picture, is taking healthcare out of this outside system and instead integrating it into your daily life.
Mm-hmm.
Do you think that, Grace, I'd love you to jump in, but I mean, please jump in first. But my question underlying all of this is great. How close are we to proving this saves any money down the road? Because in the end, we've got to hope all this monitoring and eating less cake and going for a walk and all this kind of good stuff, but also monitoring people with chronic illness, like Carium's doing, Livongo, other folks are doing, saves some money and reduces hospital admissions and bad stuff. So Grace, please comment, but think about that.
Well, I'm just going to say, if I can jump in just before Grace real quick, one thing that we do have is, and it hasn't been like across mass populations yet, because we're a relatively young company, but anecdotal evidence about a whole lot of ER issues that were averted, certainly pre-COVID as well as during. So that's like one way in which you save money, but it also depends, when you say save money, it kind of depends on who's being paid for what, how. But yes, like over the long term, you want to show that it improves health and that it decreases utilization in good ways.
Well, it's interesting when you talk about save money, because we're talking about from the patient perspective. So here we have patients that are using RPM and virtual care and are preventing themselves from escalating. They're self-triaging with all of these virtual digital healthcare tools and avoiding the ER. And then you see the press releases saying, oh my God, the doctors are like, well, where are my normal heart attack, stroke, high blood pressure patients? Hospitals are hemorrhaging money. So do they actually want us to do that? I'm kind of confused, because if telehealth is supposed to be successful, it should meet patients where they are so that they can live their best life where they are. But it sounds like everybody in the industry is so disappointed because people are not going to the hospital. Help me out here. What's going on?
So I'll just re-quote Bob Wachter again from UCSF, where he says that they're back up to normal elective surgeries. They're up to the same number of admissions, including admissions from the ER, but total visits to the ER are down about half where they are. So a lot of the people who I think were using it, are sort of self-selecting out. But apparently the implication would be that at least at UCSF, they're catching the serious stuff. So I don't know. But your bigger point, which I'd hammer on, and Vince and I, you and I have talked about this for years, is that, yeah, you want to spend less money in the expensive place. You want to spend less money in the hospital and the hospital admissions and, the places that cost a lot of money. But the system currently is not set up for anybody, well, other than the payers, it's not set up for provider organizations to easily benefit from spending less money in expensive places because they get paid to spend money in those places. Until we figure out this new system, which, I've been banging on this continuous clinics thing, but you can call it a capitated medical group or whatever it is. Until you figure out a set or Medicare Advantage making regular payments to provide organizations and ACOs or whatever the hell you want to call it. And we have seen a bit of this coming. You've had Blue Cross of North Carolina, Blue Cross of Massachusetts has been talking about doing this. Till you really get a pattern where that makes sense financially for the big healthcare providers, they're all going to want to go back to having their beds full and their ERs, their ERs humming and their elective surgery suites, going fast. And
so Matthew, I actually saw an editorial in I think it was in JAMA this week. First time I've seen it, it's really a pretty obvious point where the authors made the point that stability of revenue really is something that we've seen totally go out the window with COVID. And that's a reason why we need to have new systems of payment. My golly, we need to have more systems that are population-based, trending towards capitation. And maybe we'll actually see the providers becoming the pushers of this as opposed to the resistors of this. Sorry to be optimistic again.
So I'm going to turn to my two DC friends here, because you're near the corridors of power and near the corridors of power that we are. I'm not hearing any of this in the Biden platform. I mean, is there a Biden? There is a semi-Bernie Sanders, semi-Biden platform out of the Democrats, right? Which, some people know. I know Ro Connor, our local Bernie Sanders supporting representative down in the South Bay of San Jose, has said he's not signing off on the platform because it doesn't guarantee Medicare for all. But I mean, there was a lot in the ACA, as you know, Lygeia, about promoting and changing the way we pay.
Yeah.
It doesn't really change. Hadn't really seemed to have worked. I'm hearing much more about doing a redo on that, maybe.
I mean, it's interesting because I think healthcare was sort of like lined up to be one of the central issues in this election had things not gone crazy, but now COVID and the economy and really basic things, like even when you think about healthcare right now, it's much more about COVID and do we wear masks or not, and kinds of issues like that. I feel like there's less general turn around the policy pieces of it. But Maggie, I don't know, what are your thoughts on what you're hearing?
It's all about the money. And I, quite frankly, don't believe politicians. I've worked with them and they do a platform to get themselves elected. And they may or may not do anything. And when wearing a mask has become a political statement, imagine if during the Blitz in World War II, that people in London had said, I'm keeping my lights on because it is my right, right? The Germans would have bombed them. I mean,
they bombed them anyway, but yeah.
I mean, they would have had lights by which to.
Hey, this is America. We have our right to be selfish and stupid.
Well, it is quite. I mean, we're coming close to the end here, and I'm about to go around the horn and I'll see what I think is going to happen next year. But I'd say that we're seeing these different surges, but it's clear that America has not got this under control the way some other countries have. Even the countries which had bad problems, like the UK, and Spain, and now basically quashed it. It also seems to be rotating regionally here in a way that, because I guess we have more travel into states, and although they're starting to, it'll pick up in Europe with the travel, it's now starting to hit the Midwest a little bit, even though it's sort of starting to peak in Florida and the South. So I'm with you this, but I mean, as Vince mentioned, you've got a healthcare system which is pretty much, has run healthcare policy in this country for decades. And I don't know if there's enough willingness to change it. Say, we went through this thing might happen again. We really should figure out a different way of doing it. And that's where you'll get the pressures in on whoever is in power next year. I'm
going to be optimistic with you one more time.
It's mad optimist here.
I apologize. Look, there's been, over the last 4 administrations, consistently, Republican or Democratic, there has been a consistent but extremely slow shift towards value-based payments. That's not going to change. Even the Trump administration finally got that right. Yep. It's just happening very slowly, but it is happening.
All right. Well, we'll have the mad optimist have the last word of the general chat. I wanted to go around the horn and ask what you're all looking for, hoping for, expecting, looking out for in the next couple of weeks. So Grace, we'll start with you.
I'm going to leave everybody with a pro tip. Here's what I'm noticing. So COVID-19, patients that were hospitalized for COVID-19 are starting to get their bills. They're astronomical. I'm going to advise everyone to get a copy of their medical records from their stay for 2 reasons: to be able to review and negotiate your bills when they come in, and for now what we're seeing, long haulers who are going to possibly need long-term rehabilitation or chronic type illness care, get those records so that you can move on to what your next steps are, because we're not telling the people who have been impacted by this pandemic that this is a strategy they need to hack the system.
Good advice. Maggie.
I'm waiting to see what platform the Dems come out with related to healthcare.
That's it. Short but sweet. I mean, they're giving like AOC 60 seconds to speak. So I don't know how much time Harris or Biden's going to get. But
I'm also looking to see some kind of movement on the whole. So CMS has said they're going to not, after the pandemic, they're not going to reimburse telemedicine. There's not going to be equity. And so I'm looking to see how this shakes out.
Or if the pandemic ever ends, right? Which maybe the permanent pandemic. Lygeia, next couple of weeks.
Yeah, I've been traveling around the last couple of weeks, and I'm usually in DC, but I was in Wisconsin, Chicago, a bunch of other places. One thing I noticed was severely different attitudes toward things like mask wearing, and the social pressure, peer pressure element of that was huge. And I'm looking, I don't know, I noticed how different it was, and the pressures are different here versus there. I am hoping that we can use more positive memes to reach those who are anti-mask wearing and start flipping that way of thinking.
Vince.
I'll flag 2 actually fairly obvious, but I think important canaries in the coal mine to watch in the next couple of weeks. One is college football. Will we see more announcements like the Big Ten where they shut down the season? Or will they continue, and can they make it successful? And the other one to watch is schools. You know, boy, that's been controversial, but and some of the early school openings have not gone well. I think we need to watch those very carefully. They'll be really strong indicators of what kind of fall we're going to have. I think I would probably opine this is an area where I'm actually not particularly optimistic, because we're just seeing too much pressure towards reopening for the sake of the economy, where all the indicators are not good right now.
Yeah, I
watch those areas.
Yeah,
football,
I agree with you.
Football and schools.
I agree. I think we see no football in those schools, no schools for Christmas. I don't know what the NFL is going to do. Baseball's having a stuttering comeback. European soccer seems to have made it back, but as we said, they're kind of past the mass of their wave. So I agree with you on those two, and I think the politics of this, especially given that we still don't have an agreement yet on another stimulus package, and if we do, it's not going to be as good as the one we have, and yet you're going to really not see, you know, I believe Mike Pence was claiming that they've now created more jobs than ever because of the V-shaped recovery of the good numbers last week, some crazy stuff being said. But the economy is, you know, I think going to go into continue into free fall, even though the stock market is going into, you know, ballooning up over the next few weeks and months. And we're really going to get into this and the impact of the pandemic. And there's going to be a lot of blame cast aside as we get up towards November 3rd. It's going to get ugly and unpleasant. And I think somewhere in the middle of that, somehow we've got to keep our eye on the ball about how do we reform the healthcare system for better. And, you know, I'm with Maggie. I'm looking for that platform, but I also want to see the reaction of the healthcare system, because maybe Vince is right. Maybe, you know, people in the healthcare system now do want to see a real change and come to a more stable financial foundation than dealing with elective surgery and whatever the Ian Morrison says, what the German Minister of Health said when, you know, what the in German about how we actually pay for stuff and cross-subsidized from employers to Medicare. So I think we may start seeing discussions about that while we're dealing with no football and no schools. All right, that's it for this week. I want to thank everyone on the THCB gang. I want to draw your attention to a couple of things that are happening on THCB. Next Wednesday, we have our first THCB book club. We're going to be reviewing, Jess the Master and myself will be reviewing Unhealthcare, the new book from Hemant Taneja, the guy who funded Livongo and Rowe and a bunch of other stuff, the venture capitalist, who's written a book with Steve Klasko, who's the CEO of Jefferson Health System, a very interesting, iconic health system CEO. And I think we're going to have Glenn Tillman, the CEO, the chairman of Livongo, is going to come on that with us. Hope that all comes together. So please take a look at that. You'll see some entries about that on THCB, and you will be able to download that book and read it and hopefully get your questions in. We'll be doing that. And the next thing is, as I mentioned at the start of this, Jess the Master and I have done a really interesting program about the Livongo, the Teladoc Livongo merger, which hopefully will be out late Thursday afternoon or early Friday. You can take a look over the weekend. We have 7 or 8 health tech CEOs who are either competitors or directly affected one with the other, commenting about that, and should be a lot of fun. It's certainly been an interesting experience for me putting it together. I've never done such intensive TV production. Still, talking about intensive TV production, here we go. I really want to thank my colleagues on the THCB Gang today. Grace Cordovano, board certified patient advocate, all the way from the wilds in New Jersey. Maggi Cary and Lygeia Ricciardi, both of them hanging out in DC, although we hear Lygeia's been around the country spreading COVID, or hopefully not picking it up. And Vince Kuraitis, incurable optimist from the wilds of Idaho. That's the THCB Gang for the 13th of August. Signing off now. We'll see you same time, same place next week with a new gang. I'm talking probably more about money.